welcome, welcome, welcome. Good afternoon, and welcome to the AACR ABCF Special Education Session. We are so glad that you can join us in person and virtually. And For those who don't know me, I am Karen Russell. I'm with the American Association for Cancer Research, and I'm here with Dr. Vivian Carter. So we've teamed up with the Alamo Breast Cancer Foundation, and we're going to bring yet another exciting session dedicated to breast cancer research for breast cancer advocates. So, Dr. Vivian Carter is the chair of the Department of Psychology and Sociology at Tuskegee University, and she'll be discussing bioethics and cancer. She's also the former director of the community engagement for the Tuskegee University Health Disparities Institute and past president of the National HBCU Research Network for Research in Health Disparities. Dr. Carter is also the former assistant director for community outreach with the Tuskegee University National Center for Bioethics. We ask that you keep all questions until the end of the session, and you can add your questions in the chat box. And for those who are live, go ahead and go to the mic. You'll be able to ask your questions there. So, ladies and gentlemen, you are in for a treat. Welcome, Dr. Vivian Carter.
Well, Karen, thank you for that introduction. And let me just say that I am delighted to be here with you with the American Association of Cancer Research. Just absolutely delighted. I'm the presentation that I'm going to share with you today is about a topic that moves beyond just thinking about the legal aspects of research, but going more so into the what we call the moral aspect of it. And I've taken this presentation, which is a part of what we call a 3 week, actually, a 3 week training program. And I've kind of condensed it down for this session. So I'm hoping that everything will work out. And I think it will. I think we'll be just fine. All right. Let's see. Bioethics 101. We're going to first start with bioethics, the definition, so that you have a clear definition of what bioethics is. Then we're going to move into looking at the ethical concerns that bioethics actually begins to address as a practice. And then we're going to talk about the actual questions that we actually begin to ask from a bioethical standpoint as we discuss research. And for many of you, I know that you are advocates, and many of you may have participated in research studies. And so we're going to go back over maybe some of the questions that you should ask. And as you are participating on many of the community advisory boards, you may find this beneficial. And then we'll look at the core ethical principles. And then I want to begin to study and actually apply this to probably one of the most infamous studies that we've ever talked about when we talk about mistrust or when we talk about research participation. And that's the United States Public Health Service study of untreated syphilis in the Negro male. So we'll take a look at that and try to begin to go back over some of these bioethical principles and think about how they were applied, or even think about how we as uh, individuals think about that study and the implications. Okay. Bioethics. We're going to kind of break this down, and this is what I usually do with my classes is I break the term down. We look at bio. Bio basically means life, quality, it means health, wellness of human life. Bio, which is life. Ethic means it's the principle of right conduct or right action to make quality life decisions. So when we think about this term, putting them together, bioethics, we're thinking about principles of life, principles affecting life, the quality of life, the fullness of that life. So, bioethics as a philosophy is the bioethics is the ethics in service of the bios, of bio meaning life, in the service of lives, all lives, life lived fully, not just physiologically, but we take into account the social, the political, the cultural, the economic, and the spiritual. And again, this is a very, very dynamic philosophical perspective, and it's very encompassing in terms of how we actually operationalize it, put it into action, if you say. Bioethics is both an academic and it is an intellectual and practical interdisciplinary field of study or inquiry that deals with issues of the rightness or the wrongness of actions regarding life events. And we ask the question, what ought to be done about the issue? It's a problem solving enterprise. It's again very engaging because it encompasses multiple uh, dynamics and it is contextual. Some of the basic concerns that we have in bioethics is the well being of all people, especially for us being in the South, being where we are located. We're especially interested in African Americans. We are in a very rural Southern community that is largely African American. However, I will tell you the dynamics are changing. We're getting a substantial Hispanic population as well as a multilingual Asian population. So again, those dynamics are changing, but it is about the well-being of all people. We look at disparities among all people with specific emphasis on health and education regarding racial and ethnic minorities. These are the groups that are most vulnerable and most at risk. It is the abuse of vulnerable populations, specifically in research and life events, that we focus in on. There are potential coercion of research participants. We have to look at that. Potential for exploitation, the potential for disparate representation. Disproportionate, I'm sorry, representation within research. And then there's potential for inappropriate use of the study design and the data. Okay. So we these are concerns, these are questions that we raise to the researchers and we ask and try to train community members as well to be observant about. But this is what bioethics is for. It is a very inquisitive, problem solving enterprise that asks some very fundamental questions, not only from a legal standpoint, but from a moral standpoint. Now, some of the basic questions is, and then when we're thinking about the ethics of virtue here, what kind of person ought I be in order to live a moral life and make good ethical decisions? And it asks you to really search yourself in terms of your morality and in terms of that impacting the decisions. And remember, we're looking at for the good of all. How should we see our human relationships? What we do can affect others for good or for ill reasons? What obligations and duties do I have to others? What's my responsibility? I understand my responsibility in terms of myself, but how does that impact those around me? We really need to think about that in these days and times. What do I owe the common good or public interest in my life as a member of society? We've got to recognize our interdependence on one another and our obligations to one another. There are four major principles that guide bioethics. That is respect for autonomy, beneficence, non-malfeasance, and social justice. When we think about respect for autonomy, when we're talking about respect for autonomy, this is due appreciation for one's capacities and perspective, including the right to hold certain views, to make certain choices, to take certain actions based on personal values and beliefs. Autonomy of action should be the subject to controlling constraints by others when it results in harm to self or others. Now, let me make this clear, and I simply say this because I have been doing a lot of community engagement, a lot of studies now that we're dealing with the pandemic and issues regarding the vaccine and the mandates and and issues. And one of the things that we are, while I respect, trust me, I respect your right to hold certain views. That does not release you from the consequences of those decisions. And when those decisions either harm yourself or they harm others or place others in harm, then there has to be regulation. Now, I'm not saying that it has to be something forced or mandated, but there has to be some type of regulation because that becomes now a public safety issue. In trying to understand and deal with this issue of autonomy and its somewhat sometimes infringement or encroachment in regards to public safety and public health. But again, respect for autonomy has to be first and foremost. We do have to recognize, I don't have to agree, and you don't have to agree with the views of the researchers or the physicians, but there has to be a respect for you as the individual in making your own decisions based upon your personal values and beliefs. That must be first and foremost. Beneficence. This principle requires one to abstain from intentionally injuring others and to further the importance and legitimate interest of others. Okay? You cannot intentionally injure other people. We have to look at, again, the impact that it and the effect that it's going to have on others. The duties requiring one to abstain from harm and to create positive assistance. You're to do good and to promote good, kindness, and charity. Okay, that's the beneficent component, beneficence. It's not intentionally injuring others, but seeking to do the most good and to promote kindness and charity toward others. This is the one that I find most interesting to me sometimes is non-malfeasance. And when we're talking about non-malfeasance, it's the obligation of a physician, a researcher, not to harm the patient or the participant. Simply stated, this is a simply stated principle, and it supports several what we call moral rules. Do not kill, do not cause pain or suffering, do not incapacitate, do not cause offense, do not deprive others of the goods of life. And basically, I summarize this many times is do not engage in misconduct. Do not engage in unlawful acts. I often think about this when I'm thinking about we do a lot of education programs, we do a lot of community awareness programs. One of the things that I often talk to the funding agencies about, as well as my own research partners, is that you do not go out and promote this screening and do all this educating, and you don't have any means of supporting or helping people once they are diagnosed. If I'm telling you and I'm paying for you to get a mammogram, and it turns up that you have, they detect cancer, I need to be right there with you going through the treatment phase. I mean, that's meaning lining up with organizations are providing, and sometimes I provide it out of our grants to where we can assist these patients. But education without follow-up support is, you know, I think it's a miscarriage and a misrepresentation, and we can't continue those practices. We have to be able to provide to follow through with these individuals. It's not just a one and done thing. But again, that's me and how I follow through. Let's move on to justice, distributive justice. And here, when we talk about justice from a bioethical standpoint, we're talking about it contextually. Okay, it's a very contextual term. Uh, pardon me. There's fair, equitable, and appropriate distribution in society determined by justified norms of distribution that structure part of the terms of social cooperation. There is no quote unquote single principle. As I told you, it's contextual. To each person according to an equal share, to each person according to individual need, to each person according to acquisition in a free market, to each person according to individual effort. Excuse me. And then we have to each person according to societal contribution, to each person according to merit. One thing that I like to stress here about social justice and the idea of equality. And I often stress this to people who talk to me about diversity and inclusion and equality. There can be no equality without equity. When you have a society that exhibits inequality, there has to be equity before there is equality. So I just want to make that clear. The practice of bioethics. The practice of bioethics involves understanding. That means that we analyze the issue. And when we're talking about analyzing the issue, we try to get at identifying what's the ethical dilemma. What's the dilemma here? What are we really concerned about? And then looking and trying to identify what options are available. And then we have to move to the action stage where we have to actually make a choice. And that's choosing the best option. We now have the options, but which is the best option for this situation? And we have to think, all things being considered, what should be done. And in terms of thinking about what should be done, we should be asking, is it good? Is it right? Is it just? Whatever we're engaging in and the decision that we make, again, thinking about, does it promote the good? Is it the right thing to do given this context? And then we have to think about the equity, the justice component of this. Now, we've gone through the four primary major principles. Now, I want to take you through probably whenever we think about mistrust or questioning research, again, the primary target, and regardless of whether you know the full story or don't, the primary term that comes up is the Tuskegee syphilis study. And the actual study name, title of the study, is the United States Public Health Service Study of Untreated Syphilis in the Negro Male. This is a study, and I put this here intentionally. This particular study ran from 1932 to 1972, a period of 40 years. Now, let me then first explain. There was a precedent for the study. In 1890, in Oslo, Norway, there was a study conducted of untreated syphilis in Caucasian men. It ran for 6 months. Okay? There was an actual study. And so we have that precedent there. So it's not like, oh, they just targeted the. No, there was a precedent. They did know how syphilis behaved in Caucasian men because of the 1890 study in Oslo, Norway. In addition, in 1929, the United States Public Health Service was involved in a study funded by Julius Rosenwald. And the focus of this study was to study the treatment and the prevalence of syphilis in rural Southern communities. Now, Macon County was chosen because it housed one of the premier health facilities, and that is John Andrews Hospital. It was the premier health facility for Black people in the South. Not only those in Macon County, people came from Georgia, they came from Tennessee, they came from Florida, they came from Mississippi, because it was one of the premier places and one of the only places, again, you're talking 1929, where Blacks could actually be treated and gain adequate medical treatment. So they came there for medical care. Okay, you're talking about an institution that housed the clinical society, where Black physicians were perfecting and conducting groundbreaking techniques. There were many white physicians that came to learn these techniques and go back to their communities. But that is why John Andrews, that is why Tuskegee was chosen, because of the health facility. They didn't have to go out and, send things miles away to be diagnosed. You had a major facility right there to do it. So that was why they came to Tuskegee, but it was the United States Public Health Service that conducted this study. They used the facility. Now, it was found that Macon County had one of the highest rates of syphilis in the 6 counties they surveyed. And of course, because think about the facility that was there. The findings also indicated that it was possible to provide mass treatment in rural communities, especially Black communities. So here again, they're saying, okay, mass treatment can be done here in the South, and it's possible, and they did provide treatment. So again, it was not unusual for the men to seek health care, and they'd already had in 1929 a study where they actually treated, syphilis. Now we get to 1932. The United States Public Health Survey initiated a study in Macon County, Alabama. The study was comprised of 423 syphilitic men. Please understand me, there were 423 syphilitic men. They were not injected. They did not, the United States Public Health Service found that they had 423 syphilitic men enrolled in the study. They also enrolled 200 unaffected men in the study. So you had 423 men with syphilis, 200 who did not have syphilis. So you could see what the actual change was for a person with syphilis versus what the actual change was for compared to a person who did not have the disease. The target population were Black males between the ages of 25 and 60. The procedure for this was that they had physical examinations, they had x-rays, they had spinal taps. Again, remember, the duration of the original study in Oslo was 6 months. This study lasted 40 years. Understand something else. These men were told, they were never told they had syphilis. These men were told they had something called bad blood, which could have meant anything. There was never any intention from the title of the story. There was never any intention to treat these men. You can see here they did go through, and remember, this lasted for 40 years, where they had eye examinations, they took spinal fluid, they took blood samples. After 25 years, they provided, and this is in our archives, they provided these men with certificates of participation. And here again, this is 25 years that they are looking and evaluating these men again without any intention of treating them. And they never told them. They never told these men. They never told these men they had syphilis. They never provided any treatment, even after penicillin becomes readily available as a treatment for syphilis. It isn't until 1972 when the story breaks about the syphilis patients. And that study was presented to the public by Jean Heller, who was given information from another journalist, Peter Buxton. Now, the apology that was given to the survivors by President Bill Clinton um, was not just met with an apology. It was met with action to establish a bioethics center on the campus of Tuskegee University as an oversight. At Tuskegee, we review a lot of research proposals and provide constructive feedback in regards to the bioethical issues and implications of those proposed studies. We provide a lot of support for the CDC as well as other governmental agencies as well as local agencies because we believe in having an informed public and having people to understand clearly what their rights are as participants. We want and need people to be more knowledgeable in their participation because we're not going to address any of these healthcare issues without all of us standing up and participating. And we need to do that in a competent and a safe manner. This is a picture that was taken of the survivors of the syphilis study at that time. And you see there the Surgeon General David Satcher, who was there and one of the proponents, along with Dr. Benjamin F. Payton, for promoting the center there as an oversight. And all of these men are now deceased. But the gentleman in the middle, Mr. Pollard, is the one who brought the attention of their participation to Mr. Fred Gray, who was one of the lawyers who basically took the United States Public Health Service, basically took them to court and won. Now I want to thank you for that, for listening, and I would kind of want us to think about this study and think about some of the ethical principles. How can we begin to look at this and begin to think about it from an ethical standpoint in terms of what was done? And I'll answer any questions.
All right. Thank you, Dr. Carter, for that. That was a very good presentation, a lot to think about. I do have a couple of things that I've jotted down myself that I wanted to kind of get your thoughts on. So, kind of going back to the study, the syphilis study, what do you think are the lessons that we should have learned when it comes to the treatment of cancer or for cancer patients?
Well, I think when we're talking about the treatment of cancer patients, again, first and foremost, informed. Make sure that they're fully informed and about their treatment and that they're fully engaged in the decisions. Sometimes, and I can say this from sitting with members of my family as well as sitting with people who participated in studies with me. Many times we leave decisions up to the physicians.
Mhm.
It has to be, a group decision. You, the physician, and your advocate.
Right.
I often want to tell people because I've been in that position. I've sat in that office, and that was my when I had my first mammography, they found
Mhm.
a lump. And my doctor was like, okay, now, yep, we got this back, and there's definitely a lump, and I'm now go down the hall to the surgeon. And I'm like, what are you talking about? Oh, well, wait a minute, and I'm sitting there by myself.
Mm.
And this is going completely over my head. And I'm seeing stars. I'm studying this stuff. I'm seeing stars, and I'm like, wait a minute. Now my mom is a practitioner. She's a healthcare provider. Immediately got on the phone. I called my mother.
Mhm.
And my mother was like, okay, keep me on the speaker, go back in there, sit down with him, and let's talk about what he saw, where it was,
Mhm.
and
Mhm.
and we really but she had to do this to walk me through because I'm telling you, it went out of my,
Yeah.
and then I made the decision to go ahead with getting the lumpectomy, and talking with the surgeon. But again, we had to you have to they have to take time to explain, time
Mhm.
to walk you through this. You need time,
Yes.
okay?
Totally agree.
And I
Okay.
think that sometimes that's not there. It's just, well, that's what they told me I needed
You
to
just
do.
have to. Mhm.
Okay, you need to know why you're doing it,
Understood.
and,
Yeah.
and, and have that understanding. Okay, and that's part of the autonomy. And
Mhm.
again, your informed consent, not just, okay, this, when you tell me this, okay. No, informed.
Mhm.
The other part of it is, again, understanding. Okay, a lot of people are informed, but we don't clearly understand. We don't understand the jargon. That's the reason why I say something about what ought to be done. You know, okay. We need to have that clarification, that there is understanding. And
Mhm.
again, one of my big pet peeve, I'm not going to just educate you and send you, on your
Mhm.
way. I'm going to be right there with you.
Mhm.
I have advocates and groups in place. I work with a lot of cancer centers. I work with community support groups because, again, it's a community.
Right.
You're not in this by
Right.
yourself. You can't.
True.
It is so difficult. And
Yeah.
I'm one of the most private people. I know y'all wouldn't believe that right now. But I try to be most private, but I'm telling you, that is the time when you need that community around you. If it's just to know that they're there, you don't have to be reaching out 24/7, because that's not everybody's,
Right.
that's just not how they operate. Okay, but just the idea of knowing that that's there when I need it,
All right.
if I need it.
Yeah. Okay. Thank you, Dr. Carter. We have a question from the audience, from the live audience.
Hi, Dr. Carter. I'm Christine Grogan. I really appreciate your talk. I'm going to jump out in 6 minutes to go talk to another industry partner of mine about what you just spoke about, and that is women of color healthcare disparities around breast cancer. I work for an organization called Brave Breast Advocation Education Foundation. We've been focusing for about 10 years and finding that women of color, one of our board members' wife died of advanced stage cancer because she had dense breast tissue. And how can we get that out? Because women of color, we know, have dense breast tissue. I happen to have it myself, and I'm a private person too. However, we have to advocate for women to get further than just a mammogram, MRIs, ultrasounds, because that is part of why people of color die earlier with breast cancer, because they don't diagnose it. So it's sort of a question, and how can we make this better? Thank you.
Oh, no, no, I wholeheartedly agree with you. One of the things that I also do is I talk about self-exam. Nobody knows your body better than you. Okay, we already know most of those diagnoses do not necessarily occur from mammography. They occur from people feeling that lump. And so I encourage people to do their self exams, go for your mammograms, and again, because African American women have denser breast tissue, I often ask them to speak with their physician about further screening procedures. But again, that has to be again referred by a physician. And so I do talk to physicians because yes, we are as women of color, okay? We have denser breast tissue and we have to be aware of it. But the best thing to do is also stress self-examination.
Hmm. Yeah. We have someone in the comment that asks, did the Tuskegee experience help launch the idea of patient-informed consent forms? And if not, do you know when the US begins using these documents?
In informed consent actually came out of the Nuremberg trials. A lot of those safeguards did come out of the Nuremberg trials, and it was preceded by the Belmont report.
Okay. Okay. Um, I have another question in the comment section that says, or comment and a question. I often feel my doctor does not tell me everything. They want to hold on to the little information so they can ultimately control the choices I'm going to make. How can we use this argument to ask for more time?
Mhm. Well, there's always second opinion. Okay,
Hmm.
there's always a second opinion.
Yeah, I
and
think
and,
people don't
and
do
but
that.
again, I tell people, there's nothing wrong with seeking a second opinion, but we do want to make sure that we move in a timely manner when it comes to cancer.
Hmm. Okay, we have another question from the audience, live audience.
Hi, this is Sandy Stanford. Hi, Karen. Hi, Dr. Carter.
I
Uh,
said,
Thank you for an important conversation. As I always called it, the Tuskegee study, also. That's the way I learned it. As patient advocates, part of our job is to not tell, but educate doctors, nurses, PAs about what is most important for the patient. And bioethics is extremely important. A long time, well, not that long ago, but a few years ago, as you know, there were some studies, research studies that were done that were, how can I put it nicely, not using the correct information to get out there and, padding it a little bit. And so there are things that hopefully that we as patients, or if we were on the grant as the patient advocate, that maybe we could have stopped. So are there resources, books, articles out there for patient advocates to learn more about bioethics?
there are several books that are out there on bioethics, especially the institution that has the largest library is George Washington University. But there are several books that are out there in regards to bioethics and advocacy. Um, I'm
Do
right
you know
now.
the names?
I'm blanking on that. And I can get you a list of sources, but I would suggest that you first start with Georgetown University.
Awesome. Thank you.
Okay.
Oh, you're welcome, and thank you.
So to follow up with that, Dr. Carter, I mean, if you can, once you settle down with this and everything, if you could give me some names, I'll be more than happy to share that with
Mhm.
some of our advocates who have attended. So yes, keep your questions coming. Um, Let me see. I do have, actually, let me just do a quick follow up. I know someone else followed up with asking if do we know of a good jargon dictionary? And then she's been looking for one. So I guess jargon in regards to bioethics and kind of, having that conversation with your doctor. If I'm not right, please correct me if that's what you're asking. So. Okay. So we'll go with that. If there's any information or that they can get to in regards to having that kind of conversation with their physician?
I'll tell you, there is one. The textbook that I use for my class is actually by Dr. Thomas Leveist,
Okay.
and he it's about the disparities, but he makes reference and to the language, and being what literacy. That's it, about health literacy as well as medical terminology.
Okay. Okay.
And then so his book on health disparities is excellent in terms of, and then there's a whole section there on health literacy.
Okay. All right. Thank you so much for that. And then, as you were presenting, one of the things that I was thinking about is when it comes to breast cancer screening, I know that, people who are young may not get screened because they're so young, but do you think that bioethics has some kind of role into that?
Well, again, that's being educated
Mhm.
about the disparity. That's the justice issue. As we know with breast cancer, and as I've told you about the law I helped to change in Alabama for prostate cancer screening for Black men. Alabama was ahead of the curve in terms of raising the screening age, because we recognize that Black men cannot wait to age 50 to be screened for prostate cancer.
Mhm.
I'm again a proponent for 35, and I still push for that to be raised. For Black women, we know that many young Black women in their early 20s, have been diagnosed
Mhm.
with breast cancer. And one thing that we don't do is we don't talk about it in our families.
Mm.
A lot of this has been hereditary,
Mhm.
and you didn't know it because you didn't know what grandma or great grandma, you didn't know what Aunt Jean died from. You just know she had cancer and she died.
Right.
Okay.
Right.
No, we need to know these things. We need to understand the genetic traits, as well as how our diets contribute.
Mhm. True. Yeah. So we have to take our own responsibility in
Yeah.
educating ourselves and educating our families. Hmm.
But also pushing, again, you got to push those policymakers. We got to keep, again, these doctors know. They're knowing they're continually seeing these 20 and 30-year-old women coming in with breast cancer. They should be saying something, but if they aren't saying something, then we as advocates should be up there
Hmm.
talking to the legislators, the lobbyists.
Right. You're absolutely right. You're absolutely right.
We got to get political. As they say, it's the it's the squeaky wheel that gets the grease. We got to get
True.
political, or as my grandmother would say, a closed mouth does not get fed.
Very true. Okay, so if there's any other questions, go ahead and put that in there. If not, we can wrap it up. I have a couple of last words. So while I'm waiting to see if there's any questions, I just want to say my thank yous now. Of course, a thank you to Dr. Carter. Great presentation, great information, great knowledge. So thank you for that. Thank you for to the Alamo Breast Cancer Foundation. Again, another partnership going well. Hopefully, we can do this again next year. And of course, thank you to those who are watching live and virtually. We're here to provide you with as much information as possible. And just a quick little things for our advocates who are still here. Make sure you guys check out the Alamo Breast Cancer Foundation mentor sessions that's happening every night. Also, the annual meeting, the AACR annual meeting, will be April 8th through the 13th, and that's going to be in New Orleans. So, people, you want to be there. The Scientist Survivor Program, that deadline has actually been extended to January 17th. So you still have time to get your applications in. If you have any questions or emails, go ahead and email ssprogram@aacr.org. And let me just see if there's any little thing that else I want to mention. Yes, so you can learn more about some of our AACR advocacy initiatives at aacr.org or email advocacy@aacr.org. So, okay, how can we join forces? Okay, join us. Okay, cool. I think that's that. I don't see any other questions. I don't think there's any other questions in the audience. No, let's check. Nope. Okay. So I guess with that said, I want to thank you again, Dr. Carter. Great information, something to think about. Bioethics, informed consent, education. How are we going to educate our people? Educate the lobbyists. The legislation. So we have a lot to think about. Lots of work to do. So with that being said, I think that's it.
Well, I just want to thank you for giving me the opportunity to again speak to the group. Alamo Breast Cancer, fantastic. Thank you so much for this opportunity.
All right. All right. Thank you again. And we'll see each other next year.